Okay, so welcome everybody to the South Texas Regional Family Medicine Grand Rounds. We are partnered with the South Central AHEC, and our mission statement is there for you as well. There we go. If you have not, those who are in person with us, there are some sheets in front of you, but we do kindly ask that you please make sure that you use that QR code that's in orange or the one that's on the screen. If you could use that to sign in, we do have to turn in an attendance record to the CME office. Doesn't necessarily mean you're registering for credit, but we do need an attendance record if you could take care of that for us. And also for those who are joining us and you are looking to gain CME credit, you will see here an activity code. I'll go through some instructions here in just a moment, but if you are claiming that credit, please make sure that you do that before midnight tonight using the code listed on the screen here. So those who have not yet registered, you'll just need to make sure that you email your, text your email address to the toll-free number listed there. That should get you set up with an account. And then from there, you can text the code that is showing here on the screen for today's presentation. You'll text it to that same toll-free number listed. But of course, if you have questions or concerns, please feel free to reach out to me. Those who are claiming credits, be sure to check your CME transcript every so often by going to the UT CME office website listed. Also, questions, they can be directed to their office or you can reach out to me as well. And if you are not aware, we do also offer credits to the AAFP. So please make sure that you do take advantage of that if you are a member. Their information is listed there. And we just want to make sure that we do point out that it is our goal to meet these nationally established physician core competencies that you see on the screen. And there are no conflict of interest for our presenters. And I'm going to have Dr. Shi go ahead and give a brief introduction.
They will have three amazing speakers we're able to invite and come in person. So I'm going to just do a brief introduction for all three of them, for all of you here. We'll have Margaret Costantino, and she's the executive director and co-founder of the Center for Refugee Services. I think a lot of our residents know. So this is an independent nonprofit agency providing social services to legally resettled refugees in the San Antonio area. She's a lifelong San Antonian. So her background includes licensing as a professional mental health counselor and 20 years in higher education. So in 2006, Margaret retired from UTSA to pursue a PhD in counselor education supervision, which led to a post-retirement career as a university instructor and recipient of the UTSA prestigious Master's Teaching Fellowship. So her interest and training led her to focus on community mental health, especially with resettled refugee population that often struggle with problems related to adjustment and the profound loss of home, cultural, and professional identity. So next one we have Heidi Worabo. She's a clinical associate professor in the School of Nursing. She's a co-director of the Doctor for Nursing Practice Program and Family Nurse Practitioner Track Coordinator. So during her career as a nurse practitioner and educator, she has focused on improving healthcare access to culturally inclusive care for immigrants and refugees. She's the co-director of the San Antonio Refugee Health Clinic. She works with a team of interprofessional faculty and students in providing holistic primary care for refugees. She also practices the Wellness 360 Employee and Student Health Center at the UT Long Campus. So her impact as educator has been recognized in 2018 as a recipient of the Patty L. Hawkins Faculty Excellence Award, and in 2021 was a Presidential Excellence in Teaching Award. She was indicted as the fellow in the American Academy of Nurse Practitioners in 2020. Is nominated on the university-wide task force to develop interprofessional education opportunities that support the university's quality enhancement plan. There's a lot of really, really impressive recognitions there. And last last but not least, Dr. Haq, a lot of us already know, he was a former graduate from our residency program. And he is a board certified in family medicine and sleep medicine. He's currently serving as the senior medical director with UMA, overseeing UMA adult and pediatric primary care and express med services line. He's also the co-founder physician of Bari Community Health Center and CEO for the past 9 years. Making healthcare accessible to all and bridging the gaps in healthcare is Dr. Haq's mission and passion. Thank you. Here, Margaret.
Good morning, everyone. I'm Margaret Costantino. I'm honored to be here today, and I'm doubly honored to be here with my co-presenters, both of whom I know and have worked with for years, and think that they represent excellence in medicine as well as compassionate service to many of the people who we're going to be talking about today. Okay, I'm going to get to. So I'm going to be talking about the social support that's essential in order to provide refugees with the care that they need from a holistic perspective. I'm not a medical practitioner. My background is licensed counseling, mental health counseling. So if you want to think of me in broader terms as a caseworker, I'm happy to assume that role because that's what I do in partnership with these two wonderful individuals. And I can tell you that when we start talking about the free clinic in just a few minutes, Dr. Worabo will also testify to the fact that I'm really busy at the clinic, but not on the medical side, on the social support side. I want to talk a little bit about resettlement and how it differs from migration. Some of this you're already going to know, and you've experienced a lot of what I'll be talking about, but please bear with me and ask questions, because what I've learned over the last 13 years working with refugees is that things are changing, and they're changing fast in the world of immigration. We want to talk also about the common biopsychosocial barriers to cultural acclimation. And I will talk a little bit about the Center for Refugee Services and why we exist and how we provide support to new arrivals. When refugees come to our community, we call them our new neighbors. We are in a partnership with them, we respect them, and we realize that these are intelligent and people who, thank you, Dr. Haq. They're intelligent people who are simply out of their milieu. They don't know how to navigate our systems. So in the initial stages of resettlement, people need a lot of support. And then finally, we'll talk about partnerships that mitigate these barriers. Okay, so when you think about immigration, it's really kind of a dry, boring topic, but immigration is not the same as, resettlement is not the same as migration. Resettlement pertains to people that have come from war-torn countries. This is what they're seeing. Ah, here you are. Okay, now we're on the same page. So resettlement really has to do with a process that starts long before a refugee arrives in the United States. They are under the protection of the United Nations if they are designated as refugees, which means that they have fled war in their country and gone to a third country or a second country seeking safety. So you can think about the people in Syria who during the civil war fled to Turkey seeking safety. And now, of course, they're in a much more treacherous condition with a natural disaster that nobody could have predicted. People from Afghanistan, and I'll focus a lot on Afghanistan because we're seeing a lot of Afghan people in our communities, and not only San Antonio, but throughout the United States. The process of migration is very complicated. Some people come to the United States because they want to. They're not refugees, they're immigrants, and they come here because they want to. But a refugee really has no option to go back home. In many cases, wars can last for decades. In the case of Afghanistan, for example, people who were 3 and 4 years old when the United States came into their country are now educated adults. They're professionals. So many individuals never knew a time in their lives when there was peace. And before the Americans came to Afghanistan, of course, there was a period where the Mujahideen were in control of the government. And then prior to that, Russia. So these decades of turmoil and war can go on and on and on. People flee for one reason only, and that is to save the lives of their children. So it's difficult. Sometimes adults will say to me, I could have put up with this, but my children had no future. So to register as a refugee in another country, the United Nations will vet them. There was a long process of interviewing, of fingerprinting, of doing background checks, on and on and on. And then they have to apply for resettlement in one of the UN-sponsored countries, one of which is the United States. When they are approved for resettlement, it can sometimes be 10 or 20 years down the line. We see people from that come to the United States from Burma, for example, that were in refugee camps for 20 years. They grew up, they had their children. So national identity oftentimes becomes very confusing because children are born in one country, the parents are from another. So it's very complicated in a lot of different ways. But legal admission to the United States means that they can come here and get permanent residence. The Congress sets the annual cap on how many people can come into the country. And during the prior administration, we knew that the numbers of refugees admitted legally shrank quite a bit. So in the last years of the Obama administration, we had been building up to a time where the president was recommending 100,000 refugees come into the United States. Then when there was a change in the administration, President 45 came in and declared, no, we were going to shut the door on a lot of those programs. And gradually over the 4 years, it dwindled down to about 15,000 that were admitted to the United States from some of these war-torn countries. So the backlog in other nations is tremendous. I say that now because the gates are starting to open again. We are expecting more refugees to be admitted into the United States during this fiscal year. We are going to see them in our clinics, I promise you. And then those who have been here 5 years, 10 years, 12, 20 years, however long, are still in our community because this is their home. We see a lot of secondary migration as well from state to state, which means that the insurance they may have had in other states is not valid in Texas. Texas did not expand Medicaid, as you know. And so people who had Medicaid in New Mexico or New Jersey were delighted to get health insurance, and they come to Texas and find out it's not the same, that it's a state-oriented program. So there's a lot of confusion about who is eligible for certain benefits and what benefits and so on and so forth. Just kind of moving along, resettlement agencies have contracts with the State Department and the Department of Homeland Security to resettle people in the various cities throughout the United States. So the resettlement agencies in San Antonio are 3. There is Catholic Charities, Refugee Services of Texas, and RAICES. Those agencies get federal money to greet people at the airport, find them an apartment, help them get jobs, enroll their children in school, sign them up for Medicaid, which they may or may not get. Children very often get Medicaid much easier than their adults do. And so the children are usually better prepared for any kind of medical needs because they come with insurance, but the adults, maybe not. All that assistance, there's a certain amount of financial assistance attached to resettlement, but it's only for a few months. Other states have refugee resettlement assistance for years. Texas provides 8 months of resettlement. So during that time, people do get some help with their rent. They do have to go to work. They have to learn English. They have to learn the educational system, the transportation system, how to speak English. And then after 8 months, all that goes away. So we're seeing tremendous numbers of people who cannot acclimate in 8 months. I couldn't acclimate in 8 months, and I'm fairly educated, but I couldn't acclimate 8 months if I was in another country. So there's multiple barriers that are in play here, and community services are vital for success. Now, the Afghans that are coming are not refugees. The ones you're seeing in your clinics and that we're seeing in our office are called humanitarian parolees. They got out of Afghanistan much quicker than the normal resettlement process that they should have gone through if they'd had more time. But because the United States withdrew the military from Afghanistan, these people were evacuated, over 80,000 of them in a matter of weeks. They were brought to the United States and given humanitarian parole for 2 years. That parole came with a work permit. They can acclimate, go to school, they can work, pay taxes, all the rest. But after 2 years, it stops. So that 2 years is coming up in August of 2023. So in a few months, Congress is going to have to make a decision what's going to happen to these people. As a coincidence, I wrote an op-ed article that will be in the Express News tomorrow, stating the Afghan Adjustment Act is hanging in Congress and needs to be passed to give these people a pathway to some sort of future, some sort of permanent residence. They don't have that assurance right now. So imagine the stress level of families who do not know what's going to happen to them. Okay, so stress is one of the predominant factors that you will see running through the situations of many of the patients that you see in your clinic. Parents are worried, kids are worried, they don't know what's going to happen to them. And so from a public health perspective, from a biopsychosocial perspective, people are under a lot of stress that leads to depression, anxiety, and other related health conditions that will develop over time. Okay, there's someone else coming in. Okay, thank you. So what are some of the barriers we see? We see language, we see culture, family dynamics. People from Afghanistan, for example, love big families. In America, that doesn't seem to fit our norm anymore. Large families of 10, 12 children, one worker in the family supporting them. Uneven cultural acclimation over time. The children tend to acclimate a lot faster because they're going to school 8 hours a day. They learn English, and you will oftentimes see little children coming into the clinics to interpret for their parents. And in my opinion, that is not a good model because the parent, number one, is not going to learn English, and number two, children shouldn't be listening to certain kinds of things that are being discussed in a clinical setting. They have ongoing financial stresses. They have to struggle with unemployment, and they are already coming from war. So you see war injuries, you see blast injuries, amputations, bullet injuries, and so forth. And again, going back to the fact that people do not have insurance. Many of the clients that we see have transportation issues. I keep messing this up. Hold on, guys. Okay, so I think you're getting the point I'm trying to make is that a lot of support is needed to help people move forward. And welcome to certainly visit us if you are inclined to do so.
All right, well, I'm happy to go after Margaret because she pretty much gave you an excellent background as far as the context of our patients that are coming, not necessarily always by their own choice to the US, but when they asked me to participate in this panel, I thought, oh man, 15 minutes.
we could talk for hours on refugee healthcare. So I decided to just narrow it down to our Afghan patients, because that's the majority of the population that we've been seeing over the last 3 years, especially with the U.S. withdrawal from Afghanistan and 80,000 people coming all at once. We were really, really inundated, and this was right after COVID, after we were just opening up. And so we've been really, this has been on the forefront of our mind at the San Antonio Refugee Health Clinic. So just to provide a little background, we started in about 2011, and this is a student faculty collaborative clinic of UT Health. So some of you might have rotated through there, volunteered there. I know from your faculty, Dr. Reimers comes on some nights. And so this is a weekly free clinic for refugees, and run by our student leaders. So every year we have new, about 3 medical student leaders, 3 nursing student leaders, and 3 dental student leaders. So it's a interprofessional clinic where we collaborate to provide basic care, whatever we can do, and as well as facilitate linking them with services that they need. As you all know, if you try to refer somebody to a specialist, it's not that easy when they don't have insurance. You have to figure out, okay, who do you know, who's an ENT, or who do we, how can we get them signed up for CareLink or Medicaid if they qualify? And so our collaboration is crucial for really providing the health needs of our population. And so that's our mission, is to just provide that care. We have medications that the Center for Medical Humanities and Ethics, they have grants that help support our medication supply, as well as our laboratory services. So our patients go to University Hospital Lab to get their labs drawn, funded by the grants. So it's really a collaborative effort. And so that's just the background of the San Antonio Refugee Clinic. And I'm happy to be part of that. And from the nursing school perspective. And so I don't know if I can read from here, but these are the objectives that I just wanted to cover in these next few minutes. I think it's important to understand the context, and Margaret touched on some of that, you know, as far as what it's like in Afghanistan as contrasted to here, and then understanding those cultural views of gender, the gender roles, especially related to reproductive health, is really important as healthcare providers, and then identifying key strategies for providing culturally effective healthcare for women of reproductive age. So in the healthcare in Afghanistan, I just found some statistics. Most of this data comes from a 2015 survey by the USAID. And I didn't find too much other good sources of data within the country related to maternal health or reproductive health. But as the US has been there for a couple decades, in 2014, there was a lot of investment in the healthcare system, in community development. As you can understand, from a war-torn country, you know, starting in 1979 with Russia, and then after 10 years they left, and they didn't really achieve their goals, and then the US was there for the last 20 years. So they have just seen one kind of devastating war after another, and so they're just trying to build up the healthcare system, and it's 80% of people in Afghanistan are rural. So you can understand how it would be difficult to extend healthcare, but they were achieving 77% coverage there. As far as maternal health, almost half of women deliver at home without a trained birth attendant, you can see. And so that tells you kind of the setting a lot of your patients might be used to or coming from and have experience with. And Afghanistan has one of the highest maternal mortality rates in the world. So they also have one of the highest fertility rates along with that. So average 5.3 children per woman. And contraception is, according to, again, this 2015 survey, is not very highly utilized within Afghanistan we're talking about. And literacy of women is very low too. As for most of you probably know, a lot of women are not allowed to go to school, especially with the Taliban taking over. And so gender roles are really important, and really important for you as a healthcare provider to understand and know where your patient's coming from. At the same time, statistics like this, and this again is from Afghanistan, not from the US, but it was done by the USAID. 46.1% of women report that they have been abused by their husband within the past 12 months. So that seems extremely high, right? At the same time, whenever you see big statistics like that, you want to always remember to give that individualized care and not make any assumptions, but have that awareness. And of course, you know, women are married very young. So when it comes to, you know, folks moving to the US, immersed in a new culture, drastically different. If I had to think of one group that was very, very different from American culture, I think of the Afghan culture, especially in terms of the gender roles and the women. And so I have worked with students on different projects throughout the years, and one of them most recently was interviewing women on their experiences giving birth in the US. And so we did 20 interviews with women one-on-one, and that was just really interesting to hear their stories. Most of them had also given birth in Afghanistan, so they kind of contrasted their experience. So in Afghanistan, they tell us, you know, you'll be in a room of 30 women all giving birth at the same time. You know, there might be one or two doctors around, or nurses, midwives. And so when they come here, we ask them, how was it here giving birth? And they're like, wow, we got so much attention. You know, they really kept saying, wow, they really gave us a lot of attention, and they really appreciated that, of course. And so that was a big contrast from where they came from. And then they also really appreciated prenatal care. I know when we think of people coming from other countries not used to preventative care, but they really appreciate that they can get checked, they can make sure their baby's okay and mommy's okay. The barriers they cited were the transportation. So most of the women don't drive. They rely upon their husbands to take them to appointments. And if you can imagine, he's the only one working in the house, and then he has to take off work to take his wife to all the prenatal visits. You might not be surprised if they don't show up because of that transportation issue. And then interpretation. So a lot of our women, they're not literate in Pashto or Dari. I think the majority of our patients that we've been seeing speak Pashto. And so if you're thinking of giving written handouts, you know, you might want to consider pictures or videos for education related things. So just being aware of that factor. And then the changing role of the husband. So I think that's really important as you're providing care for women. When someone's pregnant and they're coming to you, this is a family affair, right? And so not only listening to the woman about preferences, but also thinking about the husband. One woman told me that it was really uncomfortable for her to have her husband in the labor delivery room. And I was like, oh, really? I never thought of that. And I said, was your husband uncomfortable too? And she's like, yeah, that's totally not the culture back in Afghanistan. You just don't, you know, have that in front of your husband. You usually have another female or mother-in-law or something with you when you give birth. But so I thought that was surprising, but they felt kind of like it was an expectation to have him there, and that's why he stayed in the labor room. So different things like that you might not think about as you're caring for families. The gender concordant providers is really, really important. They told me stories like their friend, she was giving birth and her husband took her to the hospital, and in walks this male provider, and the husband just took her right out and brought her back home. She delivered at home and started hemorrhaging and bleeding, and they had to bring her back emergently just because they did not want a male in the room. And so I think this is not with all of them. Some of the women told me it's okay. In-person interpreters as much as possible. We have all female teams within our patient rooms for the women, especially if they're there for a reproductive issue. Yeah, if it's a male interpreter, even on the phone, they don't like that and they won't share what's really going on. And so as a healthcare provider, you need to know what is actually going on with your patient, right? And she needs to feel comfortable enough sharing. And that was one of the big things that I've seen with women is they say we're really shy. We don't want to talk about this as a taboo subject. One article I was reading, the woman had said like she didn't want to say actually what was going on. She was just, even though she knew she had a vaginal infection, she was like, my legs are burning. And that's what she was telling the doctor. And so it does take a little bit extra time. Number one, through the interpretation, but also really understanding what they're trying to say and communicate to you. But giving that time, that's kind of what they really appreciate is your caring attitude and taking that time to listen to them. And then as far as how assimilation might change their perspective on family planning, like Margaret mentioned, 9, 10 kids is pretty normal back in Afghanistan, but once they move here, they're realizing, whoa, it's expensive to have kids here. So they do, maybe want 4 or 5 instead. And so, and again, this is of course different for each family, but just keeping in mind some of those things do change as they settle in the US. And we did do some focus groups with both men and women a few years back about their thoughts about child spacing. And that's really the word that we use when we're talking about contraception is child spacing rather than family planning or contraception. And some women really wanted natural is better. So learning more about the natural method of tracking ovulation and preventing pregnancies that way. And then they just had a lot of fears about the side effects and especially its effect on fertility. So women's value really has been taught to them that it's in your fertility and your ability to have children. And so they're afraid that these different birth control methods might affect that. And so having giving them all their options and letting them know if their menstrual period is going to go away with this method is really important because they want to know that they might. I had one woman say, she thought the blood was all building up in her abdomen because she wasn't having a period every month with this contraceptive method. And so things like that are important to take the time to explain. And so just to kind of wrap it up, really encourage you to take a strengths-based approach. I'm from a bicultural family. My husband's from Ethiopia. And so I'm always learning new things about his culture and the way that he grew up from his family. And I like to take this strength-based approach, like every culture has its strengths. And so, for instance, the breastfeeding, every woman that I interview, they have no problem breastfeeding. And they're really good about breastfeeding for 2+ years. Like, oh, what can we take from that and help our population here in the US to use those principles there. The strong family ties, so respecting, the family and the husband-wife relationship. I know that 40% statistics of abuse kind of sits in your mind, but a lot of the families that I talk to, the woman is very thankful when her husband is supportive, and they're just have different roles. And so respecting that in terms of most of the authority comes from the husband, and she has to kind of run it by him. There was some literature I read about, some, and one of the focus groups also, she shared, well, I just take contraceptives, but I don't tell my husband, So when you're counseling your women about contraceptive options, you might want to, do it with just the woman. And then if you have that continuity of care, can see them back and see, okay, as far as the relationship, do you want to involve your husband in this decision and educate him on it too? Because a lot of times she'll leave it up to him, which method that they use. And so his education is really important as well. And the other thing, educating, yeah, I think I talked about that. So I think that was all that I had. I know, I think just, leaving with the continuity of care is really important. Some women will not share with you on the first visit, but maybe the subsequent follow-up visits, they'll warm up to you and start being more open to sharing what their problem is. Because we all know if we don't know if they don't tell us what they're feeling or their symptoms, then we can't make a diagnosis and provide treatment. So I think those are my tidbits.
Good job.
Takeaways.
Do you want to switch places?
No, good. Just the computer over here.
Okay.
All righty. Good afternoon. It's an honor to be here to see some of our mentors and senior residents that we followed and some of the junior residents that we get to work with. And it's an even greater privilege to be able to talk about the patients that we try to serve. And these are the patients who put us, who give us the respect and the love that make us go the extra mile. So my name is Dr. Suhaib Haq. I'm, as mentioned in the introduction, I'm a graduate of this great program. And I think I, learned a lot, and all my faculty and all my mentors, fueled my passion to continue to work with our patient population in San Antonio. So I was very happy working with University Health System, taking care of the underserved patients for almost 10 years. And at that time, Obamacare was being rolled out, and I was hopeful that everybody will get insurance and everybody will be living happily ever after, but that didn't happen. Like the presenter mentioned, that the Medicaid didn't get expanded. So there were a lot of people, thrown off the bus. And so me and a couple of other doctors, we thought about, okay, who's going to take care of these patients? So let's do something what we can. We have the mission to really help the patient who are in our county who don't have any place to go, but this is another group that is there. And so let's do something. So we started, Bari Community Health Center almost 9 years ago. It's a free charity clinic for patients who don't have insurance and cannot pay for their care. It's a 100% volunteer-run clinic, and we focus on adult primary care. We do see patients from all walks of life, all religion, race, ethnicities, languages, and luckily we have a great team that also brings amazing diversity in terms of the background and cultures. And being located, co-located with Islamic Center also provides us a comfortable place for a lot of immigrants and refugees to come and relate to. So this picture that you see over here, on the top left is our team of volunteers. Usually at one point we have about 30 to 35 volunteers helping with the clinic. The clinic is open on Saturdays and Sundays, but there's a lot that goes behind the scene in terms of outreach and planning and all that stuff. We are very proud that we do provide the quality care that our mentors, trained us to do. So we have, numerous awards from different national organizations in terms of quality. And if you see these patients without any charge and free, it doesn't mean cut any corners. We do provide the top-notch care that we provide in our clinics here in university or medical school or VAs. And most of our faculty are with great organizations. So So as I mentioned that, we wanted to take care of patients who don't have any place else to go. And we didn't know that we're going to be taking care of huge population of refugees and asylees and immigrants. So even though we have some filters set for people to have some level of financial eligibility, but anybody who walks through the door, we take care of them as long as they're not being abusive with our services. Primarily over the last many years, we have really focused on the refugees, the resettlement people, and especially when they fall out of the initial 6 to 8 months of government-assisted programs, and they have nowhere to go. As I mentioned to you, we do have people volunteers who are from Middle Eastern backgrounds, from Persia, from India, Pakistan, Bangladesh, and South, Hispanic. So when we get some of these patients, we try to provide them the comfort, that they are in an environment where we understand their needs a little bit better. Over these years, we have developed, amazing partnership, and these partnerships have helped us expand our services, see more patients. We have Margaret over here. She's an all-time strong supporter of us. She, one thing about Margaret, there was a patient who was a one-off case that many things happened to him, and he was sick, needing a lot of medical attention, but he was eligible to become a citizen. And I reached out to Margaret, and she went out of the way to pull resources after resources. That gentleman was so sick that he was on his deathbed. When the immigration people came to his deathbed, and he had his oath ceremony. So whenever I think of that, that is going 1,000 miles out of what you would do. And at the same time, that tells us that, the organizations, the immigration people, they took this step too, to come to his house and have them get the oath done on his deathbed. So, so we have, Margaret, and then we work with the Raisis. Sometimes we are on call with them. So especially when they have a big influx of immigrant or asylum seeker through the border, one of our doctors would be available if they have any. I know they have their own setup, but sometimes it's 10, 11 o'clock at night and they have a question. So they usually call us, and we triage the patient and direct them, and we can see the patient at the clinic. Out of the blue, I have seen many patients that are just coming from the Mexican consulate. Oh, how did you get here? Oh, the Mexican consulate told me about it. So, so Mr. Minuti is sending patients to us. Bexar County Health Collaborative is one of our new partners over the last 2 years, and they have been very instrumental in collaborating health fairs, and they have some Pashto speaking case managers that help us reach into the Afghani community, especially. We do partner with City of San Antonio for many different activities, health fairs, immunization drives. Of course, the Muslim Children Education Center, the Islamic Center of San Antonio, a lot of Afghani refugees, they come there for their prayers, and they are directed from their staff to our clinic to seek medical help. And a great, thank you and appreciation for the Department of Family Medicine. They have been standing behind us from day one. I remember when I was starting this clinic, I reached out to Dr. Hain, and that, this is what I'm trying to do. And he was very supportive of it. And then in the last 4 years, Dr. Ali has been very instrumental in helping us develop many programs. And I'm going to share a slide that even the pandemic, in whatever it was really, we're in the deep of the pandemic, we were doing amazing programs with Dr. Ali's leadership and support. And then, a couple of things that we do is the health fair. It's open to everyone. You will see a few pictures that, this is a good place for immigrants and refugees and our, San Antonio community members that don't have insurance and come and get their screening done. Our health fair is a little bit different than the usual community health fairs because we do provide active screenings. Most of the health fairs, they have blood pressure, they have sugar testing, maybe cholesterol, but we have blood pressure, sugar, cholesterol, kidney test, eye exam, dental exam. Of course, the mammogram bus is there, kids immunization, sports, kids physical. We have hearing test. This year, it was amazing to have the skin clinic participate. We provide, skin cancer screening, and I think they did an amazing job. And they did find 4 cancers out of the 12, 13 patients they saw. When they reached out to me, I said, people, is getting skin cancer. They're going to take off their clothes and may not work out, but we were surprised. You'd never know. So when people come to these health fairs, within a span of about 3 to 4 hours, they get, significant amount of screening done. We do for depression screening. We did a project with Dr. Ali to find out what was the most culturally competent way to screen people for depression, because in a lot of cultures, it is a taboo. When you say somebody you're depressed, it is, I'm not crazy, because they think of when you say depression, it's being crazy. So we did come up with some of the things. So of course, sleep apnea and other related screenings. We have had many COVID-19 and flu vaccination clinics at the center and in the community. Especially, even though Bari does take care of the adult patient in the clinic, but we try to do whatever we can for the pediatrics as well. So we have had, back to school shots sessions, eye camp for kids. Also, the volunteers help with food and home supplies. The different nationalities that we see, immigrants and refugees, are definitely majority Afghanistan, and there was a time there were a lot of Burmese as well. There was a time we had a lot of Somali immigrants, but unfortunately, a couple of incidents happened in the community that majority of them left San Antonio. There were 2 murders. 2 of the Somali taxi drivers, they got murdered. They didn't find who killed, so the community got scared and they fled. So another immigration after, so of course, Sudani, Nigeria, and the list goes on and on. And at this time, we still see a majority of our patients are a local Hispanic community, mostly 40%. 30% are, you can say the new immigrant asylees. And then the rest of the 30% we see are, established, Middle Eastern, Asian patient that we see. All right, so this is just a picture. Top left is the immunization drive. The turnout, we had about 150 kids, all of them Afghani. And the key over here was that the healthcare collaborative had really motivated community leaders in the community that, motivated them to come and get this done. On the right, I think that's just the second event we had. You can see the kids over there. In the middle, we have Cher, is in the white shirt. He is one of the community, navigator, helping with translation and getting all these patients. I think this guy's getting the flu shot. Of course, we did provide the dental because that is a big gap in the community. So we had some dentists doing screenings. And the bottom center is when we did the eye exams for the I think this was a big group of Guatemalan kids that was with the races, and a lot of those kids were complaining of eye issues, and So Rice has reached out to us, and we worked with the UIW School of Optometry to do that. On the right side, again, whenever we do any event, we have Ask a Doc available on site. So if any medical issue comes, we can, start the process of treating or guiding them in the right direction. So over these years, what we have gained some understanding, being an immigrant myself, coming from a culture that is closer to most of the refugees, whether by social setup or whether by religious, I have a little bit of understanding, but still there's a big gap that these refugees and asylum seekers, taught us. So on the left side, you will see, what are the things we understood by taking care of them, because there's no handbook. And so we go, we learn as we go. And on the right side is, what are the things that help us to find a solution or to get to a solution. There's no perfection in this. We are learning every time we see an immigrant. There is a new perspective. They have a new, we get a new understanding what the patient, we have been talking about X and the patient thinks we're talking about A. If I had a little bit of animation in this slide, there would be a popping up in the middle, understanding the solutions. So I wanted to, the culture, both the presenters over here, did speak very well and true to the cultural difference. It's not ever different, it's just an opposite culture. There's no wonder it's called East and West, there's a reason it's called East and West. The perspective are different, the gender roles are amazingly different, the family dynamics are different, the expectations are different. And to make our work meaningful, we had to have key people who can infiltrate this in the community and break through this cultural barrier and activate them from inside. So if you look on the right side, so when we saw that culture was a barrier, we really need to penetrate into this community through community leaders. So we started to talk to had meetings with community leaders, and especially the most impactful what I saw was through the health collaborative, that they already have established grounds in the community. So we try to reach out from them. Family values, there's nothing else for me to say. But as they have a different mindset. Like the gender role, the family is run by the father, but at the end, the father is still scared of the mother, but he tries to run the family. The solution for that, it was two-way street. They cannot change the way they think about their families. We are foreign to them and they are foreign to us, and we need to have a two-way street here where we can talk and we can try to understand each other's values and respect them. And that's the only and the best way to move forward, because there are things that they are never going to change. And there are things that, we can only provide a good care if we understand what they are expecting and they understand what I'm trying to tell them is in their benefit. Priority list. So healthcare is the last thing on their list, unless they're pregnant. That's they can't do anything about it. But everything else, is not on their list. The first thing is to find shelter for the family. The second is to find food. The third is education. Fourth is job. Fifth, if it comes, is health. And it only becomes a priority if the limb is falling off. If it is not falling off, can be, taken care of later. So, and I wouldn't blame them. I wouldn't blame them. I wouldn't tell them, hey, your blood pressure is high. Come see me in clinic tomorrow because I need to talk to him. He doesn't have time off from work. He's the only one earning the bread. If he doesn't go to work, he doesn't have food to put on the table. So what we have learned is that we need to be out there and offering them the resources. So when they're ready, we are there. And we have our doors open and we have our arms open, because that's the only way they can start to get plugged in into the health system, so they get the care they need. Health literacy is one of the things we identified. They don't have any good expectation from us. They don't know how we work in the health system. And from where they come from, like Dr. Worabo mentioned, in one room, there are 30 ladies laboring at the same time, okay? Now that's only 50% of the people that get to the hospital. The 50% is laboring at home. So for them, most of them may have never seen a doctor. So when they come to us, they don't understand how we work, how our appointments work, how many patients can we see, how much time we have. When we write a prescription, where does it go? What does insurance means? To do this, I don't understand what insurance really means. So for them to understand is a big challenge. So that's something that is in Bari, that's in the refugee clinic, that's in family health center, that's in UMA clinic, that's all over the place. So for that, I think it has to be a collective effort. And I think some of the UMA people are looking into educational programs for these people as they enter our health system. They have more formal education. Of course, language is the barrier, so maybe through videos. And we talked about the psychosocial trauma. Again, they may not identify with what's going on with them. It's brewing behind the scene. It was happening there. This country has been at war for the last 35 years. So no wonder there's so much family violence. You said 40–50% of the women that, reporting that. So if anything comes out to be, family violence, there has to be a psychiatric issue behind it that, is not identified as a community in them. But over here, looking from outside, we can identify it. But the thing is that, are they ready to change? And for that, the first thing is that we need them to understand what are the acceptable screenings for them, right? If I'm going to tell them, I'm going to talk to you about depression, I'm going to ask you about depression, they're going to shut off, right? So coming up with culturally competent ways, okay, let's talk about stress. And that's what one of the questions, Dr. Ali's survey came out, is that everybody's open to talk about stress. And stress is one of the symptoms of depression. So that's how we circumnavigate. And yeah, this is a busy slide, but this is really to say thank you to all of our volunteers, Dr. Ali's effort, that during the first 1.5 to 2 years of COVID, we had so many of these sessions for the community, starting from COVID vaccination to how to stay healthy, diet, blood pressure, diabetes, depression, and many more. So questions?
I have a question in regard to CareLink. So I know I had a patient that the husband was a little abusive, so he wouldn't get CareLink for the wife. So where I saw the wife was at the previous Selena's clinic, but she wasn't pregnant and she needed other help, for example, the blood pressure monitoring and all that, but she didn't have CareLink. So how do they, if the husband doesn't apply, can the wife get the CareLink, or how does that situation work out?
I think that's a technical issue over there, because in order to apply for CareLink, you need to have a proof of job. So if the wife is not working, that may be the roadblock there. But CareLink is always has gone above and beyond to accommodate. Since we're talking about CareLink, I think the CareLink is going to hire 4 interpreters to provide translation services. But I think as I told you, I'm very ignorant about insurances and stuff. So but CareLink, if she applies, they will find a way. And if not, she may be she may be eligible for other grants if it's not for CareLink. And with some of those grants, you can get limited primary care.
Thank you so much.
Bill to him.
Yes, were you able to hear me?
I did. Thank you so much.
Did y'all hear the question? It was about CareLink. And I think Dr. Haq made a very good point that CareLink will, you know, I pick up the phone and call, I will pick up the phone frequently and call the CareLink office, and they're oftentimes very willing to help. But there may be other avenues too, like either not knowing the whole situation of the family, but, you know, there are always questions that need to be asked, and we need to keep looking for answers.
You know, and you mentioned he was abusive and, you know, I don't know the whole story, but sometimes if he's being, you know, I'm just picturing him maybe rushing her out and doesn't have time to fill this out or something, you know, having an advocate, somebody in your office who can say, hey, we need this paper filled out, you know, we've got the interpreter here and we'll fill it out. Because that's just, sometimes you have to take that extra step to say that. One woman told me, she said, I really wish, you know, the doctor would just tell the husband, you know, you need to space your children. You know, he's not going to listen to the wife, but if he hears it from the doctor that it's really bad for the health of the family, of the woman, of the baby, to be having babies back to back every year, you know, so he needs to hear it from you. And so I thought that was a good, that I missed to say, but just wanted to say, sometimes you have to be pretty upfront with the husband who's making the decisions for the wife. He might not know either, you know, the rationale. So you just have to tell him, this is what needs to be done for the health of your family. So.
A question about the continuity of care. You mentioned that you built a relationship with vets over time. Do you see patients that are uninsured going to those free clinics all the time for continuous care over the years? Or eventually they find resource get established?
Could you repeat the question for the other one?
Okay, the question was, do we see continuity of care with patients going to the free clinics over and over again? I'll say that even though it's a teaching clinic, at the student-run clinic, it's a teaching clinic. It is a primary care clinic for some of these people because they will go back again and again. They have nowhere else to go. Do you either one of you?
Yes, so, you know, access is the thing, you know, wherever they're gonna find access and they feel comfortable, they're gonna try to get their healthcare need done. And that becomes their primary care clinic. I mean, for us, Bari, it is a primary care clinic. So we do see people, you know, that we've been seeing for the last 3 years, 5 years, 9 years now. But the thing is that, number one is that we should have more access. And then we need to do a little bit better job in educating them. Hey, you know, this is the right venue for this kind of support and treatment that you need. But if they come to the student-run clinic or us, we are more than happy to take care of them anytime, any day. But it's better for them for the long run if they get plugged in. So there's more continuity, solid continuity of care.
Yeah, I would agree. That's usually what we try to do. We have some patients who just want to come see us, even though, you know, it takes longer. We've got, you know, the visits are much longer, but we really try to, if you have insurance, you know, get them with the primary care, you're going to get more access to a higher level.
Dr. Costantino, did you have a question? I was just going to bring the microphone to you.
Okay, you guys were talking about education for patients. I think we need education too. And I'm coming from that part of board, and they don't have a concept of refills. For example, they don't have a concept of referral. All those things, and it took me years to find out, you know. Again, I'm coming from there, but I never got medical care there because I was sick. I didn't medical education there. But again, many things takes time for them to understand, and also if I knew that they don't understand and they feel, I behave totally different. For a patient for years to come to me and say, oh, I'm out of medication, oh, I finished my medication. And it didn't click to me that, okay, they don't know to call the pharmacy. Now we are doing all those stuff for them, don't push them. Oh, you have 3 more refills. They don't know what does it mean. And again, those are the things that I believe you guys can educate us more, the things that you learn, and we can be a better provider with that.
So I'm actually asking on to a meeting and the residents have to get on to some additional education. So, but thank you for a inspiring, moving, and informative presentation. Just a little token of appreciation for you folks. We've sort of taken a tradition from the military.
Oh.
Family community medicine. So for those, for you, you're always been a member of the family. So this is your unit coin. And this marks you as honorary family physicians here. So this is highly sought out.
Awesome.
We saw that.
Thank you.
Oh, thank you.
Thank you. This means a lot. Thank you very much.
If I could just say one other thing real quick. You will get calls from me from time to time when patients are recommended or prescribed medications they cannot afford. I will always call you and ask you, what else is there? Because we have one patient right now who's going through chemotherapy, very expensive. We have another one that's been recommended to take an injection that costs thousands of dollars. I will always call you and say, is there something else? So please understand, it's coming from a place where we need to be educated and we need to just continue helping people as best we can.
Thank you very much. It's always a two-way street.
Two-way or three-way.